This video is all about the updated bariatric surgery guidelines. My name is John Pilcher. I'm a bariatric surgeon in San Antonio, and I very commonly have discussions with patients about whether they qualify for bariatric surgery, or to say it better, whether bariatric surgery is an appropriate intervention for them at their particular stage of the obesity disease. And the answer to that discussion has actually changed recently in comparison to the first 30 years of bariatric surgery guidelines. In 2022, our national society, which is the American Society for Metabolic and Bariatric Surgery, published an updated set of guidelines that significantly expanded the pool of people for whom bariatric surgery looks like it's appropriate. I'm going to explain this in detail. I'll start by describing the old guidelines that were published in 1991, comparing those with the new guidelines that came out in 2022, and spend a lot of time discussing why the 2022 guidelines make a lot of sense. Now, as we discuss both the old guidelines and the new guidelines, we're going to use a term called body mass index, and we usually abbreviate this as BMI. And as you may already know, BMI is a combination of height and weight that gives us one number for each patient that we can compare against certain benchmarks or standards. The first set of guidelines for bariatric surgery came out in 1991 from the National Institutes of Health Consensus Conference. And those guidelines indicated that patients were candidates for bariatric surgery if they had a body mass index greater than 40, or if they had a body mass index between 35 and 40 with certain weight-related medical conditions associated with the weight. Those medical conditions were diabetes, obstructive sleep apnea, hypertension, elevated cholesterol or lipids, and gastroesophageal reflux. The updated guidelines in 2022 indicate that everyone with a body mass index over 35 should strongly consider bariatric surgical intervention, and that people with a body mass index between 30 and 35 should consider bariatric surgery if they have associated medical diseases such as diabetes. And one important effect of the updated guidelines is to open up bariatric surgical options for many more Americans. In fact, under the new guidelines, about 1/3 of Americans would qualify for bariatric surgical intervention. Think about that next time you're out shopping or you're at work and realize that many of the people around you who we think of as being a little heavy can or even should have bariatric surgical intervention. And you might ask, does this even make sense? It seems kind of over the top. I'm here to tell you that it actually does make sense, and I'm going to explain why that's the case. Let's begin by talking about why the 1991 guidelines were kind of overdue for a refresh, beyond the obvious factor that they were more than 30 years old. At the time that those guidelines were put together, bariatric surgery was still in its infancy. Gastric bypass was done, but the details of the technique were still being discussed or still being worked out. It wasn't even clear that gastric bypass was going to be a go-to operation, as there were a couple of other popular procedures done at that time that have since gone by the wayside, including non-adjustable gastric banding and an older operation called a vertical banded gastroplasty, or VBG. The other thing about bariatric surgery being in its infancy was that the surgical literature about bariatric surgery was fairly thin. There wasn't a lot of it, and the statistical quality of that literature was pretty low. And so given the fact that there wasn't true science to go to, that's why the consensus guidelines came from a consensus conference. A bunch of professors got together and hashed through their different opinions until they arrived at some pretty reasonable sounding rules of thumb about who should have bariatric surgery or who would benefit from bariatric surgery. And of course, medical and surgical technology were less advanced at the time that consensus panel convened. It's hard to understand the magnitude of the changes, so I'm going to outline just a little bit of that. In the operating room, we've got much better surgical staplers than we had at that time. We have much better instruments for sealing and cutting blood vessels in a controlled way without damaging the surrounding tissues. Anesthesia techniques are much better. Outside the operating room, the techniques for patient care and recovery are way better than they used to be. At that time, and by the way, I was in training in 1991, so I remember this stuff. At that time, there were not general availability of oxygen sensors on the surgical ward after surgery to check breathing. There was not nearly as good an ability to understand and to test and to treat sleep apnea. You could get a CAT scan back in those days, but CAT scans were very slow and they were in limited numbers and they were super expensive, so it was like an act of Congress to get a CAT scan. Cell phones back in that day were big old bricks, and the World Wide Web was just being developed. It was kind of only for geeks at that time. And surgical and medical knowledge lived in big fat textbooks that were about this big around. I mean, yes, we had electricity at that time, but things are way, way better today. Beyond the challenges that we faced in technology, there was kind of a lack of strategic understanding about bariatric surgery. There was minimal understanding about how to prepare patients for surgery and minimal understanding about optimal recovery. I was among many in that day who believed it was actually cruel to submit patients to a preoperative diet for liver shrinkage, because I thought that if they could lose weight, they would have done it already. But we've learned now that patients can be very successful with that if they have a certain short-term focused goal, and things like liver shrinkage diets have been a game changer. At that time, there was minimal understanding about how to use medications preemptively to reduce the onset of nausea and the postoperative onset of pain. And so the foundation of pain control was, after the pain already happened, to use lots of opioid medicines. Opioid medicines, you may know, they delay recovery, they interfere with breathing, and they lead to kind of more long-term complications. The tradition was for patients to stay at bed rest for a long time. 20 or 30% of patients needed to be in the intensive care unit at that time. Hospital stays of 4 to 6 days were the routine, and it would always take more than a month for patients to get back to work. So it was quite a different process than what we see today. So all these factors meant that when the consensus panel came together in 1991, bariatric surgery was a much more risky prospect than it is today. At that time, 1 or 2 out of 100 patients actually died after their bariatric operation, and many of the rest of the patients were left with lasting medical or surgical complications. For patients who didn't have any adverse events, who seemed to all go well, the positive outcomes were not as strong as we're accustomed to seeing today, because there was less understanding about how to treat the obesity disease long term and how to get the most out of surgery. So when this sensible and compassionate and intelligent group of professors got together to create a consensus in 1991, they were looking at surgical tools that were pretty high risk and very intense. And so it actually made sense that they would set the bar for intervention, or they would set the guidelines at a high level of weight and a high level of disease, reserving this intense, risky option for people who were at an advanced stage of this obesity disease. And setting this bar high, along with the still prevalent obesity as a choice narrative, meant that for many years, for decades, physicians would only refer patients for bariatric surgery when they were near unto death with the weight. And so the fact that surgery was pretty risky, along with the patients were now being selected as very risky preoperatively, very high risk going into surgery, led to high rates of complications and problems. And so there was a sense in which the expectation of risk became a self-fulfilling prophecy. In spite of these challenges, a dedicated core of bariatric surgeons saw the amazing benefits that bariatric surgery could offer to people suffering from the obesity disease. Many of these patients actually got their lives back. Dr. Walter Porres was a groundbreaking surgeon scientist among many, who demonstrated that obesity is actually a disease process. And Dr. Porres is particularly well known for identifying that gastric bypass actually has a profound, direct, positive impact on diabetes. Title of his article was "Who Would Have Thunk?" And still today, who would have thunk? But it has changed how we think about bariatric surgery. So Dr. Porres and his pioneering peers stuck with bariatric surgery. They systematized it, they improved it, and they developed bariatric surgery into a surgical specialty. In the late 1990s and the early 2000s, the next amazing thing happened in bariatric surgery. A new generation of surgeon scientists took the new laparoscopic minimally invasive tools and adapted and improved those tools so that it became possible actually to do a gastric bypass using multiple little incisions, the TV camera, and not that big old open cut. So not only did patients have less trauma during the surgery, but the less trauma also led to less bleeding, less infection, less ventral hernia, etc. And another interesting thing happened. Now, a laparoscopic bariatric operation was considered very challenging and very interesting, and so it flipped the script in terms of which physicians and which surgeons were participating in surgery. Now, after the advent of laparoscopic surgery, the best surgeons wanted to do bariatric surgery, and the best researchers wanted to learn about and contribute to bariatric surgery. And bariatric surgery became the testing ground or the proving ground for the best and the latest technology. Now, this new generation of surgeon scientists not only competed to establish the best surgical techniques and to develop or build the best technology, but also they worked together to create new and better systems of patient care leading into surgery and also following surgery. And so what happened by the middle 2000s was that we were seeing dramatically less risk with bariatric surgery. We were seeing better outcomes with better weight loss and quicker return to work. And so understandably, patient interest mushroomed. And bariatric surgery actually entered a virtuous cycle where better outcomes led to more interest, led to more volume of surgery, led to better research around surgery, and back around to better outcomes. And in fact, these 2022 guidelines that are being published and that I want to discuss a little further are a representation of that virtuous cycle, because they're showing these changes that have happened over time, and they're also leading to further appropriate expansions in the pool of people who can benefit. There were several key scientific findings that led the policymakers to create a different set of guidelines with this 2022 refresh, and as I mentioned, to expand the population where bariatric surgery was deemed to be appropriate. Number one, the findings in comparison to 1991 were much lower surgical risk. Number two, much better outcomes in terms of better weight loss and quicker return to work. And number three, a better understanding of the positive impact that bariatric surgery has on the multiple obesity-related diseases, or the absence of bariatric surgery and its adverse impact on those diseases. Saying that the guidelines are geared towards public health means that the designers of the updated criteria calibrated these criteria to target the fairly large part of the American population that could potentially benefit from bariatric surgery, in comparison to continuing without treatment of their obesity disease or with non-surgical treatment of the disease. In other words, in a hypothetical world where every American got appropriate treatment of their obesity disease, the 1/3 who have the obesity disease, and in whom the treatment was scaled up as the disease progressed, then many would have bariatric surgery, and the American population overall would be much healthier than it is today. The updated public health perspective in the new guidelines has actually reversed the appraisal of who is the ideal candidate for bariatric surgery. The old tradition, as I mentioned, which was sensible in its time, was to reserve surgery for people who were very large, very heavy, and or very sick with their obesity disease. And we would say that these people had advanced obesity disease. People with advanced obesity disease have a higher risk going into surgery, of course, and they also have kind of a damaged or a slow metabolism, so that we can't expect them to have the optimal weight loss outcomes. Now, people who have advanced obesity disease can still be appropriate candidates for surgery because they need it, but there's a certain sense in which, or a definite sense in which, the surgery is a bit too late for those folks. Logically, it just makes sense that if we apply the necessary treatment at an earlier stage of any disease, that we're going to have less risk and better outcomes. And so this change in perspective towards offering bariatric surgery at an earlier disease stage is one of the most powerful and the most positive features of the updated 2022 guidelines. Right now, some of you watching this video are probably mad at me and mad at the guidelines. You're thinking, well, that's pretty bossy. I mean, who are you, Dr. Pilcher, to say that I have to go under the knife? What gives you the right? Okay, I get where you're coming from, but calm down just for a second. Stick with me. Just a reminder that for the largest group of people we're talking about, the body mass index range 30 to 35, what the guidelines say is that bariatric surgery should be considered. For the body mass index greater than 35, the guidelines do say that bariatric surgery is recommended. But for both of these, what the guidelines assume is that you get to this point of a body mass index of, let's say, 31 or 36 or 42 after years of recognizing this as a problem and years of engagement with your medical team, lifestyle, pharmacology, exercise, food plans. And yet the disease has progressed in spite of your best efforts, and so that's when we come to consideration of bariatric surgery. Now, I know that these days that's not what is commonly happening, and that the medical system is just getting pretty good, or getting a little bit better, at engaging at an earlier stage of the disease. But when we understand that obesity is a disease, not a failure of discipline, and when we remember that obesity has an adverse effect and a strain and a damage on every organ system, top to bottom, and when we recapture the concept that the treatment of any disease is safer and more effective when we get to the early stages rather than denying its existence, it does start to just make sense to at least discuss bariatric surgery at earlier stages. And now a different group of you is thinking, woohoo, now I'm going to have surgery. I've been after it for a long time. I didn't meet the old criteria, and now I'm going to have coverage, and I need to slow you down just a little bit, sadly. Having these 2022 guidelines come out doesn't mean that insurance companies are going to automatically provide coverage for people on these new criteria. The American regulatory framework provides amazing latitude for insurance companies to choose how they implement published national medical guidelines. And I think if anything, we can expect the insurance companies to fall in line and provide this expanded coverage consistent with the new guidelines only if and when there is increased demand. So if anything, I hope this video expands awareness and expands questions and demand for medically appropriate bariatric surgery. And then regardless of the insurance issue, I hope this little history lesson has given you a sense of how much bariatric surgery has advanced in the last 3 decades and how incredibly bariatric surgery may actually be a reasonable topic of discussion for every third person you encounter in daily life. Be well.